Now, on medicine, which was supposed to be done today on Wednesday, we are going to cover some bits of it right now. Let's scroll to that page. It's okay now. So, we are going to check on STI, okay? That is sexual transmitted infection. And pretty much, or I know very well that it's not a strange thing because in Kenya, STI started, it is to be discussed as from I mean, class five, I think. Class five, you start to know what is STDs and STIs, okay? So, STI is an abbreviation of sexual transmitted infection. When you cause STD, that is sexual transmitted diseases, and it is used to denote disorders spread principally by intimate sexual contact. Principally means mainly by intimate sexual contact. Doesn't mean that STI just going to transmission. No. Some of the STIs can come as well from variety of other probable causes. Okay. Not necessarily that it has to come from sexual, but as well, it has to be transmitted sexually for it to be under STI. That is sexual transmitted infections or STDs. So there are other diseases that can be spread via sexual contact and other means like brucellosis, like Ebola. But these diseases, however, are not classified as STI or as sexual contact. Is not actually the primary mode of transmission. So that is what you're going to have today. Now we're going to check on STIs, and being that you know STI is sexual transmitted infection, yeah, so we are going to check the diseases which are transmitted sexually. We're going to discuss them in details. So we know very well that most of the sexual transmitted infections are commonly associated with any other person, can be male, female. So demographically, any person who engages in sexual activity can get this infection. Nobody is actually excluded. So low sexual usually means sexual intercourse. It can also have things to do with a close body contact, kissing, Cunnilingus, Anilingus, Fellatio, okay, mouth breast contact, anal intercourse. So many sexual transmitted diseases can also be acquired by transplacental spread, like when an organ is transplanted, when the donor is having active sexual transmitted infection with which has not been treated, and then the donor has donated an organ. That transplacental spread, when the donated organ will be implanted in somebody else, the infection can come because most of them also are hematogenous, to mean they can be spread by blood. So, so their passage through birth canal can as well be indicated, can as well be a means of transmission of this condition. Sometimes when the mother breastfeed, like that is now via lactation during the neonatal period, this condition can as well be spread. So, role of a clinician or a medic in management. First of all, you need to understand the microbiology of the STDs. That is to mean that you need to lay a proper diagnosis. You need to narrow your diagnosis up to the definitive diagnosis. You know, we normally have differential diagnosis. From the clinical history, you can deduce your DDX. But then from those investigations, you can handle like 4 DDX to one diagnosis. So that is definitive diagnosis. So when you say that the clinician must at least know the microbiology, it means that you need to deduce up to the level of, you've now reduced it from either being viral, fungal, or bacterial into bacterial alone. And if it is bacterial alone, okay, is it from chlamydia? Okay, is it from gonococcal or gonorrhea? So you need to narrow up to the last microbiome so that you don't bring confusion when you're managing. And you know very well the narrowing or reducing or ruling out diagnosis is basically one, due to the results from the laboratory investigation, two, due to clinical history. So the meticulous clinical history taking is a key thing. You need to deduce from the beginning the chief complaint, highlight them, take a nice HPI, history of presenting illness, check on the systemic inquiries, check on the past medical history, do systemic examination, physical examination, okay? Another thing that a clinician should know is how to alleviate the symptoms and prevent future sequel. Because at the present moment when the patient comes at the outpatient facility or maybe on the in the consultation room, normally they are suffering. So the complaints can be associated with headache, can be associated with pruritus, they can present with exfoliation or vaginal itchiness. Okay. So all this one comes into being. So as a medic or a clinician, you need to alleviate, knows how to reduce. Like you see, when there's fungal infection and we have exfoliation and itchiness compounded with some rash on the I mean the majora, okay, can be on the minor majora. Okay, I mean the labia majora or the labia minora. So if that is the case, the itchiness can be alleviated by anti-inflammatory drugs. So you will first prescribe anti-inflammatory drugs to reduce or to prevent or to alleviate the symptoms. If it was associated with headache, do something on the headache. If there was any pain, do something, use analgesic to alleviate the pain. Second thing is to prevent the transmission to other, including healthcare professionals. This one is always being done by either you counsel the patient and follow the four C's. That is compliance to the medication, that is contact tracing, that is counseling, and condom use. Okay. So prevention through lifestyle and behavioral modification is also the pre-weapon against the spread of STD. So that is that. So what are the common causes of STIs? So there are many bacterial or microbial, from virus, bacteria, fungi, all those one can bring STIs, okay? So despite the fact that it's sexually transmitted, there must be a bacteria or a virus which has moved from this patient to another. So like when we talk about cytomegalovirus, when we talk about herpes simplex virus, which is type 1 and type 2. We have herpes simplex type 1, herpes simplex virus type 2. We have chlamydia, we have group B streptococcus, we have molluscum contagiosum virus, we have Sarcoptes cabiei, we have hepatitis virus, we have human immunodeficiency virus. And some diseases also spread by contact, but not necessarily by coitus, okay? Like pediculosis pubis and molluscum contagiosum. They spread, they just spread by contact, but not necessarily that you have to have a sex, okay? Now, risk factors. Risk factors are the factor that can make a patient or maybe someone to be to suffer or to have the infection. So it can be a predisposing factor. So risk factors are like, for example, UTI, especially STI pathogens. Like if a patient is prone to UTI, STI can come along. Another risk factor is a female gender. So females are prone to STI. So that is being a female itself is a risk factor. Because I told you in the morning that they have shorter urethra. So the bacteria from the stool, the hygiene from the vagina can transmit because the urine also there sexual intercourse. It is easy for ascending infection. Okay. Multiple unprotected sexual contacts. Sex workers can as well come in. If you're a sex worker, you call them the siku saku guys. Okay. Intravenous drug users, the people who inject cocaine, some of them heroin, they do IV drugs into their system, they share needles, and therefore STI is commonly with them. If you're a sex worker or you are doing the ukahaba, the prostitution, you see that one is a risk factor as well. Multiple unprotected sexual contact also, I've told you that. Now, new relationship in the last 2 months, it's like you are changing ladies like clothes, also at the very, very verge of infection. So, general signs and symptoms of STI. So, any patient who presents the following symptoms should be investigated for possible STI. One, when you have sores or bumps on the genitals or in the oral or rectal area. When you have painful or burning urination. When you have discharge from the penis or the urethra of the vagina. When you have unusual or odd smelling vagina discharge. When you are having or the patient is having unusual vaginal bleeding. When the patient is having pain during sex or what we call dyspareunia. Talk about sore, swollen lymph nodes, particularly in the groin, but sometimes more widespread. When somebody is having low abdominal pain, like in females, someone is having fever, rash over the trunk. Okay, so in such a situation, the symptoms should be investigated for possible STI. So which specimen do we take for laboratory investigation? We can take whole blood or serum of the blood. Whole blood can be used to test as a test reagent for syphilis. And you know, syphilis is caused by bacteria by the name Treponema pallidum. Urine can also be taken for urine culture and urinalysis for several conditions. Can be, I mean, for several microbial, can be fungal detection, okay, can be bacterial detection when you do bacterial urine culture. Vaginal swab, eye vaginal swab, HVS or LVS, we can collect the swabs and then we can do culture with them. Rectal swab, throat swab, urethral and vaginal secretion, histological specimen like in biopsy situation. Okay, so let's see how we classify and check on the general features of STI. So under bacteria, the common ones are Chancroid. Chancroid is caused by Haemophilus ducreyi. Chlamydia is caused by Chlamydia trachomatis. Gonorrhea is caused by Neisseria gonorrhea. Granuloma inguinalis is caused by Klebsiella granulomatis. Syphilis is caused by Treponema pallidum. Now get to know, this is just very slight because in details you need to know Haemophila ducreyi. Is it a gram positive or gram negative? Chlamydia trachomatis is a gram positive, gram negative. Neisseria gonorrhea is a gram negative. What are the symptoms of the gram negative, or what are the characteristics of this bacteria? Are they spore forming? Are they anaerobes? Which medication are they sensitive to? So as a clinician, you need to know if it is gonorrhea, which choice of drug am I going to use? Okay. If it is gonorrhea, I'll take metronidazole. Okay. If it supersedes that, or maybe if metronidazole is contraindicated, I'll go to which drug. So those are the things that you should know as a clinician or a medical doctor. Fungal, we have candidiasis, yeast. The common one is called Candida albicans. Viral, we have viral hepatitis, which is hepatitis B, can be found on saliva, venereal fluid as well. Hepatitis A and E are transmitted via fecal oral route, but hepatitis C is rarely transmitted with sexual, and the route of transmission of hepatitis D only if it is uncertain. So only if infected with hepatitis B is when hepatitis D and C can be maybe available. Okay, so the one which is actually commonly is hepatitis B virus can come along with sex, but these ones are they have some exclusion. Now, up simplex is one of them. I told you we have two, one and two. You realize that they will manifest with symptoms on skin, mucosal. HIV is another viral, can come from venereal fluid, semen, breast milk, and blood. HPV, human papilloma virus, skin, mucosal contact. Iris type of HPV also cause almost all cervical cancer. You know human papilloma virus, right? As well as some anal, penile, and vulvar cancer. So some other types of HPV causes genital warts. So you don't assume genital warts. Just say that HPV only causes cancer. No, it can also cause genital warts. Other virus category is what we call molluscum contagiosum. No, I am coughing. Molluscum contagiosum virus is also brought about by close contact. Okay. Sorry. So that is that. Okay, so let's check on the parasites. Like, parasites also, we have parasites which can also be transmitted sexually, like the Tyrus pubis, the lice. Oh, lice. In Luo you call it nyuogo. We have some parasite like the one causing scabies. We call it Sarcoptes scabiei. Another one is trichomoniasis. It's a parasite, Trichomonas vaginalis. It's also known colloquially as Trich. So clinical classification, we have ulcer forming genital ulcers disease, or what we call the genital ulcers disease, GUD. Ab simplex is there, syphilis is there, Chancroid is there, condylomata acuminate is there, or what we call the venereal warts, granuloma inguinale is there, or what we call the donovanosis, and then lymphogranuloma venereum is also there. So of genital ulcer disease that they will have an ulcer on the genitalia. Like gland penile, shaft, you'll see an ulcer. Labia majora, minora will be an ulcer. Then you'll have the vaginal ulcer. So the ulcer might be very painful, especially in Haemophilus ducrei. That is the one which is causing chancroid, abs genitalis as well, but very painless in syphilis. We have non-ulcer forming, but they're still genital disease like genital warts and condylimata culinate. So vulvar lesions and genital ulcers, you get them on genital herpes, syphilis, chancroid, they have said, okay? So this diagnosis is difficult to make by physical examination alone. So you need to go to the lab and work out your results. Okay. So like you can do serological screening for syphilis, culture antigen testing for simplex virus, culture for Haemophilus ducrei, okay, chancroid. So as you can see, chancroid, that's an image of chancroid. Chancroid is an STD characterized by painful genital ulcers, and you can see in that image. So, however, the studies have shown asymptomatic carriers among commercial sex workers, although this condition can be difficult to diagnose clinically. So, suppurative inguinal adenopathy with painful ulcer is pathognomonic and may assist with what we call the preculture diagnosis. So, etiology cause of cancroid is what we call Haemophilus ducrei, and it exposure is usually through coitus, that is sexual, but accidental acquired lesions of the hands of they have occurred when you touch your private part after touching somebody who is infected with. So the incubation period is short, and the lesion usually appear in around 3 to 5 days or sooner. An increased rate of HIV infection has been reported among those patients with these genital ulcers diseases. So cancroid is a core factor for HIV transmission. And more over 10% of the patients with genital cancroid may have co-infection with herpes or syphilis. We have clinical features of cancroid. We might have vesicopustule, the vesicopustule on the what we call the pudendum. The pudendum, that thing which always attach your foreskin to the penile head of the penis, called the pudendum. Can also have a vesicopustule on the vagina or cervix, and later it degenerates into a saucer-shaped rag, also circumscribed by an inflammatory wheal. So the lesion is very tender, very painful, and produce a heavy full discharge that is contagious. It's swelling bad. You can realize that sometimes you have a cluster of may develop, and lesion typically occur the vulva, cervix, and perineal areas in women. So painful inguinal adenitis is noted in over 50% of the cases, and the buboes may become necrotic and drain spontaneously with time. So laboratory diagnosis is very necessitated. But first, when you see anything ulcers, before you go to cancroid, first rule out syphilis. So you can do serological screening for syphilis, VDRL, okay? So demonstration of the organism in pathological specimen like vulvar smear from the ulcer pass can also help in diagnosis of cancroid. Clinical diagnosis is more reliable, yeah, than smears or culture because of the difficulty in isolating this organism. So you can take history and understand. Isolation of Haemophilus ducrei is diagnostic, but isolation occurs in less than one third of the cases. You can aspirate the pus from bubo is the best material for culture. And then you do serum adsorption enzyme immunoassay. These ones also have been evaluated, and currently they have limited sensitivity. You can do PCR, yeah. You can do multiplex PCR, polymerase chain reaction. If you want to screen cancroid, simplex conditions, treponema pallidum for syphilis, okay. Then you have RPR, rapid plasminogen reagent to rule out syphilis. So you can use VDRL or RPR, rapid plasminogen reagent to rule out syphilis. So differential diagnosis of cancroid, because it is a GUD, that is genital ulcer disease, you can have differential to do with syphilis, granuloma inguinale, lymphogranuloma venereum, up simplex. They may coexist, okay? And the prevention is a key, so you should advise prevention. Routine antibiotic prophylaxis is not warranted, so condom can give protection. Liberal use of soap and water is relatively effective. Education is essential, okay? The four C's: counseling and education, condom promotion, compliance to medication, and contact tracing. Then treatment of chancroid, one, good personal hygiene is important. The early lesion should be cleansed with mild soap solution. We have something called cyst baths. They are beneficial, and antibiotic treatment as well. So recommended regime: azithromycin 1 gram orally once, ceftriaxone 250 milligram intramuscular. No, nowadays people are misusing ceftriaxone. Japan number 1 gram every time. So ceftriaxone 250 milligram intramuscularly as a single dose. Erythromycin 500 milligram orally 3 times daily for 7 days. And ciprofloxacin 500 milligram orally twice daily for 3 days in a non-pregnant patient over age 17 years who are not lactating. Okay, that is ciprofloxacin. Don't give ciprofloxacin also to a pregnant woman. Fluctuant lymph nodes may need to be aspirated through normal adjacent skin. Incision and drainage of the node is not recommended because it will delay healing. So prognosis: untreated or poorly managed cases of cancer may persist and secondary infection may develop. So frequently the ulcers will heal spontaneously and they should improve within 7 to 10 days. If no improvement, it's noted, co-infection should be checked, HIV should be ruled out, resistant strains and non-compliance must be considered. So if not treated, they may cause deep scarring in the skull in men. So that is all about concrete. The next car will check on the granuloma inguinale or donovanosis. Okay, wait for the exams.